Some questions about prostate cancer. This is one of a series of medical videos that I've posted on this subject. Today's topic is on treatment decisions. This is one of the most difficult problems many men have to face, how to decide on treatment. According to the NCCN, it should be shared decision between the doctor and the patient, and yet it's fairly complicated. The best resource for information on cancer is always the NCCN guidelines. They're updated constantly, and I recommend everyone look at those. If you go to the NCCN's website, you would see they include all the major cancer centers in the United States. I think it's reassuring to know what they consider the state of the art or the standard of care. And they do have a patient resource section, and these are basically patient-friendly booklets that go through the details, but I'll try to cover briefly some of the complexity. And I do have my own website and YouTube channel, and you can watch these videos over and over if it's helpful. So the prostate doesn't really look like that. Prostate cancer does not normally form a large lump in the prostate gland. Most men have only scattered cells in the gland and no symptoms from the cancer. If a man has a weak urinary stream, it's usually just from benign prostatic enlargement. So why is the management of prostate cancer still so controversial? Well, because many cases grow so slowly, they have no effect on the patient. And so there's no justification to risk the possible side effects of treatment in every case. And the trick is to understand the biology of the cancer to try to predict its behavior and to balance that against the man's health, longevity, and interest in therapy before coming up with a recommendation. One of the good things about prostate cancer is the 5-year survival is extremely good, 97%, probably the best of all major cancers. That makes it difficult, however, to do studies and try to evaluate the best treatment because 5 years is not long enough to compare outcome. Most men present with early cases 85% of the time. And in these early cases, again, the 5-year survival is close to 100%. Only about 6% of men show up with cancer that's already spread or metastasized. And even in that group, 40% of the men are still alive at 5 years. Most of these men live about 3 years, and now with some of the new improved hormone drugs, which I'll mention, they're pushing that survival from 3 years out to 4 or 5 years. All these areas are improving. If you compare prostate with lung cancer, lung on the left here, you can see 6% of people will get lung cancer, and 4% will die of it. And you can see how closely the blue curve is right behind the red curve. So the specter of death is falling right behind. Prostate is totally different. 12% of men may get the cancer, but only 2% may die of it. And there's a huge gap here in green. You can see between, the times at which people would be diagnosed and the time that they might die years later. Most cancers look like this. So again, back to prostate, most of the men will be diagnosed in their 60s and 70s. Those few who do die of the cancer won't die until their 80s or 90s. So there's a long gap here. And this is unusual, again, compared to other cancers. If you look at the age at which most people are diagnosed with cancer, prostate is similar to most cancers, but you look at the age at which most people die of cancer. If they do die, it's much, much longer in prostate, 12 to 14 years later. So the things that may affect the decision to treat once you've had a diagnosis of cancer made would be 1, the biology and extent of the cancer, how aggressive and how advanced. And 2, the man's health status, general state of health, other disease problems, life expectancy, personal goals. These all have to be put into the balance. If you look at the normal life expectancy, a 75-year-old man lives on average 10.4 years. If you were in the more healthy group, the top 25% live 5 years longer, so 50% better. So it's worth considering your age and the state of your health. Social Security, same thing. It actually says the average age when you get 10 years life expectancy is a 77-year-old man. And again, the same thing, you can plus or minus this by 50% based on whether you consider yourself very healthy or very unhealthy. The NCCN guidelines, you can see right here, they're quite extensive, 178 pages. They've been changed already twice this year in 2021. It's very complicated. The staging stratification, you need to get the risk group on the left here in red. And then Matt, before you can go to the right side of this chart in blue and see what the recommended therapy would be. The first thing you would have to do would be look at the path report, look at the PSA level, look at some of the other pathological features, the Gleason, the grade, how mutated, how much volume of cancer. Then you'd have to look at the imaging. Was an MRI done? Was a bone scan done? That sort of question. It may be worth considering germline testing, meaning does it run in your family? That would impact the outcome and the treatments. It's been known for years, the more mutated a cancer is, the more dangerous, the lower the cure. So well-differentiated, normal-looking prostate cells, not very mutated, have an excellent long-term outcome. If they're medium or moderately differentiated, it's not so good. If they're poorly differentiated or undifferentiated, again, meaning under the microscope, they look very abnormal, then the outcome is not as good and the relapse rate is much higher. A few years ago, they changed to the Gleason system. So Gleason was a pathologist, scores the prostate, and the man will get a Gleason score or Gleason grade group. The Gleason grade groups do correlate quite well with the risk of a relapse. But note, relapse just means the PSA blood test, which may have gone back to normal after treatment, is now started to creep back up. So a Gleason grade group of 4 with a 52% relapse at 5 years, it doesn't mean people die at 5 years. It means by 5 years, 52% of those people have some signs that their PSA is starting to come back up again. So another test besides Gleason might be to do some biomarker tests, more sophisticated test on the pathology to see if you can predict even better how serious this is. And the idea of these extra biomarkers, again, does the man have a low-risk cancer, low-risk pathology? So you can offer him active surveillance, just watch it for a while, maybe months, maybe years. Or does it have high-risk features genetically? And so is immediate treatment the better strategy? And so you want to know, would it be safe to hold off on initial treatment and just monitor the man? And since these guidelines, starting in 2018, included the option of genomic testing, these companies are now promoting this. There's at least 5 that the NCCN recommends, and I would stay with one of these 5. Oncotype DX has been around a long time. We use it for breast cancer. So you might ask the pathologist to have your path sent out for oncotype testing, and you might get a report that would look like this. It might say you have a low GPS score, low risk, and the odds of dying of this cancer in 10 years is less than 1%. The odds of ever getting a metastases is only 1%. And the odds that the path report, if you have your prostate removed, would show high risk features is only 15%. And so with this kind of report, the man may decide, well, I think I can wait a while before rushing into anything. Or you might get a report like this back from Oncotype DX that you have a high risk or unfavorable cancer. But even then, the risk of dying in 10 years is still very low. The risk of metastases is low. The risk of finding an abnormal looking gland with higher cancer is higher. But again, the survival is still quite good. Decipher is another genomic or genetic test that can be done, and it will separate into high, intermediate, or low risk. If you look at the low risk group here at the bottom, at 15 years, nobody has had a recurrence. You can combine the Decipher test with the regular staging test and get scores like this. If you say, well, how is that particularly helpful? Well, if you have a very low risk score, you might decide to do less therapy or delay treatments. If you have an intermediate score, you may want to do a little more therapy. If you have surprisingly a high risk genetic cancer score, you may want to consider even more therapy. Consider whether chemotherapy or hormone therapy should be added. So the NCCN guidelines are pretty straightforward. Once you find out what risk group you're in, it'll tell you what to do. If you have low risk cancer and a short life expectancy, they would just say observation. If you have a long life expectancy, then they would say do more active surveillance, which just means watch more closely. If you have intermediate risk, they would still offer you active surveillance if you had a short life expectancy, particularly elderly. But otherwise, they would say time to consider curative local therapy, which means either radiation or surgery. If you have high risk, then they no longer would consider delaying treatment. They would say you need to make a decision on surgery or radiation, with or without hormones or chemo. And if you have evidence of metastatic disease, then hormone therapy is almost always the first treatment. And then that's continued for years, often as long as possible. But if the cancer becomes hormone resistant or immune, there are multiple other options now available, including chemotherapy, immunotherapy, isotope therapy. So should I hold off on initial treatment? What would be the advantages if that's a good plan? Well, one advantage is 2/3 of the men may never require any treatment. You can avoid all the possible side effects and risk. You can avoid any treatment if it turns out the cancer was so small and indolent that it never really amounted to anything, and you avoided that. The disadvantages of active surveillance: there's a small chance while you're waiting, the cancer could sneak up and metastasize. About 1/3 of the men or more will ultimately require treatment, so the delay may just be putting that off. You may require more close follow-up or even repeat biopsies. And then some men just find it too nerve-wracking to sit there and do nothing but wait. So if you decide to treat, which treatment is better, surgery or radiation? The NCCN says, well, if you do surgery, they say, quote, high volume surgeons in high volume centers generally provide better outcomes. So find someone who's done a lot of surgery, particularly if they're using the robot. For radiation, they say highly conformal technique with daily prostate imaging. In other words, image-guided IMRT. So make sure the radiologist has modern equipment and knows how to use it. The NCCN lists various types and approaches to radiation. External beam has now had different speeds or fractionation schemes. There's one called ultra hypofractionation, or SRS, or radiosurgery, or SBRT. And you can actually get your treatments done in 5 treatments. So this has been a big step forward. Brachytherapy, or seeds or wire implants, is still a good treatment for early prostate. If you say, well, what do most men decide to do? Used to be radiation was more popular than surgery, but now with robotics in surgery, the results are pretty much the same. About 40% of men choose radiation, about 40% choose surgery. About 10% just do hormones, or about 10% do no treatment at all. So are there any studies that compare men who proceed directly to treatment with surgery radiation versus men who do decide to hold off and just do surveillance? In other words, are we sure it's safe to wait and hold off initially? Or is there a big chance that the cancer will progress silently and become incurable during this watchful waiting period? Is this safe? And the answer is yes, there have been lots of studies. There was a big VA study published in the New England Journal. They followed these patients out to 20 years. The long-term survival was not affected by delaying or avoiding treatment. And even if you look at just deaths from prostate cancer specifically, the difference was quite small. The only group that appeared to have needed early treatment were people with high-risk cancer. And in the current NCCN guidelines, they don't recommend waiting on high-risk patients anyway. And only 24% of the patients in this VA trial ever actually received treatment. So you can see it avoided therapy in the great majority of the men, 76%. There was another good trial called the PROTECT trial. This was published in the New England Journal. They screened 82,000 men. They found 2,600 with prostate, and they got 1,600 to agree to be randomized between active monitoring versus immediate surgery or versus immediate radiotherapy. And in the monitoring group, the decision to go on and do surgery radiation was basically based on whether their PSAs continued to rise. So how did this work out? Well, first off, 54% eventually were treated in the monitoring group. You can see if you look on the graph here, it was a number of years. Many of these people waited 4, 5, or 6 years before they had to go ahead with treatment. But this is higher than the VA trial, I think, because they were just using a rising PSA to determine go ahead and get treated. Well, how did they do overall survival? And the answer is they all did great, basically 99% 10-year survival. If you look at the survival graph for all three groups, it's superimposable. There were few more progression in the monitoring arm, but again, the survival was excellent. Even if you say of those who actually got treated with surgery or radiation, which did best among those? And the answer is they both did just fine. And most all the studies show surgery and radiation have the same long-term outcome. There usually are different side effects, sometimes more side effects. Surgery is more likely to have problems with erectile dysfunction. And in this study, surgery was the worst. And incontinence almost always is only seen in surgery, but fortunately, it's quite rare. Another study from the Cleveland Clinic, radiation and surgery, basically the same outcome. Another study with high Gleason cancer shows they all had the same outcome, whether you do surgery, radiation, with or without seeds, they come out fine. Another study from the Mayo Clinic with high-risk patients, high Gleason or high PSA, they all did well. Notice the radiation group that did well, particularly had hormone therapy added also to the radiation. And then side effects, the biggest question most men have are side effects. This was just published in JAMA. 1,300 men with low risk, 600 men with unfavorable risk. Every possible type of treatment were included. They then had the men fill out these side effect scores all the way out to 5 years. And the conclusion of the paper was prostatectomy was associated with worse incontinence and worse sexual function. Everything else was about the same. So these are the graphs from that study. It's kind of interesting. The risk of impotence was initially worse in surgery. It got better a little bit, and actually long-term, the radiation, particularly with hormones, had the worst luck with impotence. Urinary incontinence is almost always only seen with surgery. And it's not that common, and usually it does get better. Urinary irritation was a little more common with seed implants. And again, it wasn't that bad, and it got better quickly. And bowel function also slightly a little worse with seeds, but that was mild and that got better quickly. The other way to treat cancer of the prostate is hormone therapy. This goes all the way back to 1941. Charles Huggins got the Nobel Prize for this. It was the first discovery that showed cancer could be controlled by chemicals. And ironically, they were using estrogen. Estrogen will tell the pituitary to stop making testosterone. And in fact, there are multiple strategies for hormone therapy for prostate cancer. You can interfere at the pituitary hypothalamus level. You could interfere at the adrenal gland level. You could interfere at the prostate or testicle level. Or you can just interfere at the cell receptor level, which means the hormones could be out there, but any cell that needs the hormones to grow, you can block the receptor so the cancer cells won't respond. And androgens are just another word for testosterone, the group of drugs like testosterone or hormones like testosterone. And again, there's a complicated system in the hypothalamus and pituitary how this works. And again, androgens only become activated when they bind to an androgen receptor. So the cancer cell has an androgen receptor, and you can block that even if there are hormones around and the cancer won't grow. So what are the new drugs since DES, the old days? There's a zillion. There's at least 5 types of endocrine therapy, multiple chemotherapy drugs, at least 2 types of immunotherapy for prostate. There's other drugs like PARP inhibitors, which are DNA drugs. There's isotope therapy. Most of the attention in the last few years, and I suspect will continue for a few more years, is on second-generation anti-androgens. They block the receptor. Or androgen biosynthesis inhibitor. They prevent the body from making androgens. And these are quite complicated. So just to show you that for fun, enzalutamide, multiple androgen receptors it will block. And the results here are much better with that drug. Median survival is improved. Apalutamide is another good second-generation androgen blocker. Again, multiple ways of blocking receptors on the cancer cell. And again, results are much better with apalutamide. Darolutamide, another androgen receptor blockade. Same idea, much better results. And Zytiga or abiraterone, it turns out that Androgens can be made not only in the testicles and the adrenal glands, but the cancer can actually make its own androgen, and abiraterone can block all three of these sources. And you get much better outcome with abiraterone, and there are multiple studies showing improved survival and metastatic-free survival. If the hormones don't work or endocrine therapy does not work, there are multiple other approaches available now. So the treatment algorithm has now gotten quite complicated, and it probably needs to be computerized. You probably remember there was a program from IBM using artificial intelligence through Watson, but that was considered a failure. But we probably need something like this in the future. And again, this is all very complicated, but the NCCN does have patient resource guides, which are much simpler to go through. And I do have a website and a YouTube channel. You can watch these videos over and over if this helps sink in. And there are nomograms available on the internet that are considered reliable. These can be fun if you want. Sloan Kettering Memorial has a whole series. So say you would put in, what if you had a 75-year-old man with a Gleason of 7, early stage, PSA not that bad. It will tell you what the odds are that the cancer is still in the gland or has gotten outside the gland. It will tell you what the probability of a relapse, and it would say, well, only 59% of the people have not had a relapse by 10 years. But the good news is 99% are still alive at 15 years. So again, sometimes the pathology looks bad, but the survival is great. You could go back to this nomogram and change it and say, well, what if the man was younger, 60, a worse cancer, Gleason A, bigger stage, higher PSA, and sure enough, it'll tell you, yeah, okay, the odds if he had a prostatectomy that the cancer was entirely contained is only 19%. So you would assume, well, that sounds pretty serious. And the answer is, well, yes, only 12% chance at 10 years that the cancer hasn't shown up again. But the good news, at 15 years, 96% of these people are still alive. So there's sort of a disconnect between survival and some of these other pathology findings. Another nomogram is called Predict. It has some interesting graphs and tables. You could put in your stage, your age, and find out what the survival would be if you did initial conservation or conservative management, meaning you just waited. How much would you lose versus if you immediately went ahead and had treatment? What would the difference be? And there's another nomogram that has good data on what's the likely outcome. So all this is fairly complicated. So how to think about prostate cancer in the year 2021? Well, you may want to review the current NCCN guidelines, ideally with your doctor, to get him to walk you through that so you can be confident you understand the biology of your specific cancer and whether you even have to make a decision. Number two, you should probably meet with a surgeon, a urologist, as well as a radiation oncologist to hear directly what their recommendations are and to get a better understanding of the risk and side effects associated with the various treatment options. And in fact, if you have a more high-risk cancer or there's any concern about metastases, you should also meet with a medical oncologist. They have a better opinion or idea about hormones and chemo than the other doctors, and you could again ask their opinion about the local urologist and radiation oncologist. And finally, both modern radiation and robotic surgery are highly technical, and the best outcome and the lowest risk of complications accrue from being treated by a doctor or a center that has the most modern equipment for radiation and the most expertise, particularly with robotics, if that's the way you go. So do some research on your doctor's qualifications as well. And then even though the NCCN says that this should be a shared decision between the man and the doctor, you may just decide you trust your doctor and let him decide and stay the heck out of it. So for many men, trying to make all these decisions and review this himself is too much. So good luck with that. Look at the NCCN, look at my guidelines, or look at my website and my YouTube channel, and you can review this again further.